So, hello everybody. This is Mahmoud Salama, and I'm very pleased today to co-moderate our webinar with my colleague, Dr. Leena Nahata, the chair of the Pediatric Initiative Network, PEN of the Oncofertility Consortium. The practice committee and the PEN of the Oncofertility Consortium are very excited today to host Professor Kenny Rodriguez Wallberg from Karolinska Institute, Sweden, to give us a talk on the recent advances in pediatric and adolescent oncofertility practice in Sweden. Professor Kenny Rodriguez Wallberg, she is a professor of OBGYN, and she is the head of the fertility preservation program at Karolinska Institute, Sweden. She got her PhD from Uppsala University in Sweden. She is an author for more than 100 publications and book chapter. Her major research interest is to study the impact of cancer treatments on fertility potential of lung cancer patients. She is an associate editor for several international journals in the field, and she was a member of the guideline group on fertility preservation for ESHRE last year. This webinar will be for 1 hour, a 40-minute talk, and then 20-minute questions and answer. Leena, do you want to add something?
No, let's get going and we'll see what questions come up and we can go from there. Thank you, Kenny, for doing this. We appreciate it.
Okay, so we warmly welcome Professor Kenny Rodriguez to start her talk. Yes, please, Kenny.
Thank you. Thank you for inviting me to give this talk at the Oncofertility Consortium. And I will discuss in particular the pediatric and adolescent oncofertility practice in Sweden. Dr. Salama has asked me to discuss 3 papers that we published in the last couple of years. I will use the papers just to explain to you how we have established in the programs of fertility preservation services for pediatric and adolescent patients. Okay, was the wrong? Yes, and Sweden. I work in Sweden, in Stockholm, and we have our good statistics that are collected by the Swedish Ministry of Health and Welfare. And our statistics say that we have around 2,000 teenagers and young adults every year that are receiving a diagnosis of cancer and require treatment. And I need to make this smaller here. Why we should think about fertility preservation? The Swedish statistics are similar to the world statistics. In the left part of the picture, you see the incidence of cancer by ages, and you see that cancer is a disease of the older population. But when it occurs also in young people, these young people are going to be long-time survivors. So a treatment of cancer, a diagnosis and a treatment of cancer is going to create a lot of sufferance in this specific patient population that will live a long life with all the sequelae of cancer treatment. And because cancer treatment has becoming so that much efficient, we have a larger number of survivors coming every year. So if you look on the right part of my picture, so we have the cancer survival in the 1980s. If a person was receiving a cancer diagnosis, the chance to survive or die was almost the same, 50%. But today we are not there anymore. These are the statistics from Sweden, 2015, and we know that over 75% of the patients are going to survive. And if we are going to offer survival, we would like to offer a survival as good as possible, to have a life as normal as possible in the survival years. And that's why fertility preservation is important, to increase the chances of a good life in the future. And I will tell you a little bit about myself. Dr. Salama presented a little bit my curriculum. I am from Colombia. I did my subspecialist training in reproductive medicine in France. And at that time, I was working in assisted reproductive centers. I was also working in gynecological endocrinology and pediatric endocrinology. And with the pediatric endocrinology group, we performed a study that was published in 1998. At that time, my last name and my name was Rodriguez Macias. This is my father's and mother's last name. In this study, we collected the data from girls that had undergone a bone marrow transplantation. Let's see if it works here. Yes. And they were between 3 to 17 years of age at the time of the examination. That was a cross-sectional study. And in total were 31 girls that had undergone a bone marrow transplantation at that age. And following the girls over the years, so several data were available, but also we could make examinations of the girls, and we could see after bone marrow transplantation how many of the girls actually had puberty development or continued puberty development, how many of the girls actually had estrogen secretion, and how many of the girls had developed menopausal ovaries, so already at very young age. So during the last control, when the girls were about 16 years of age, we found that 29 of 31 girls that were included in this study had gonadotropin levels that were in menopausal levels. Only 2 of these girls menstruated. That was one of the first studies that were published about how damaging is ovarian is a bone marrow transplantation conditioning for the ovaries and for the future fertility. But when the paper was published in 1998, it was very, very little we could do for these patients to offer to preserve fertility. In this picture that you have seen now, I am presenting the number of articles that are discussing fertility preservation per year that are collected from the PubMed. So you see that on the left side, on 1995, it was only very little number of articles, 21 articles, 35 articles, but the number of articles increased per year. This is research in fertility preservation. This is a rapidly evolving field. In blue, you see the papers that are about fertility preservation and cancer. And in pink is the number of patients, the number of papers on fertility preservation and cancer involving children. So you see, this is also a number that is increasing. And what I have added to this graph is just the methods for fertility preservation that we had already at the beginning of the graph. In the 1995, we have already possibility to cryopreserve sperm for men. Now we have done that for many years. Embryo cryopreservation came in the 1980s, so we could add that also to the fertility preservation programs. Ovarian tissue cryopreservation was developed and the publications appeared at the end of the 90s. So we could add also this method to our patients. And then over the years, so we have seen also different methods for oocyte cryopreservation, but only the method of vitrification that has proved efficacy and that is implemented in clinics everywhere now that came to the clinical established position in 2012, 2013. So this is the evolution of the methods of fertility preservation at the same time that fertility preservation is increasing, and many researchers are also using these methods to offer to patients. I work in Sweden. I will tell you a little bit about our country and also the neighbors. And in Sweden, we have a unique setting for our medical healthcare system that is paid with the taxes of the society, and we can offer medical treatments and even fertility preservation. We using this tax-financed healthcare that is available to everyone. And in Sweden, we have only 7 university hospitals. We are only 10 million inhabitants. And at each of these university hospitals, we have established programs for fertility preservation. We work quite similarly to each other, and we also collaborate to collect data together and improve also treatments together. But outside Sweden and in the Nordic countries, we have also a quite similar situation. I collected the data of centers offering fertility preservation for women in 2016. We published this paper. It's a collection of 14 centers in all the Northern countries that report the cases of fertility preservation through ovarian tissue cryopreservation for adult patients and already for children. At that time, at that time, in 2016, when we published this article, we had already 46 women that had undergone pre-transplantation of ovarian tissue, resulting in 17 live births. So this is the situation in the Nordic countries. We work also quite similarly. We have similar healthcare systems, and we also have small populations in comparison with many of your countries that probably have a very large number of inhabitants. And it has been an advantage for us to work within this healthcare system and also to collaborate with our neighbors that had similar systems. Additionally, is an advantage that in Sweden, the Swedish Medical Ethics Council has recognized that fertility treatments can be important for people, because for many people, being a parent is the basis of a meaningful life. So for us, it has not been very difficult to implement fertility treatment and fertility preservation within the healthcare system, because this is also supported by our Medical Ethics National Council. So with all these conditions, we could start our program of fertility preservation at my center, the Karolinska Hospital, and University Hospital and the Karolinska Institute already at the end of the 90s. We had services for fertility preservation of men since 1980. And we have also the use of electronic medical records already from the 1997 or 1998. So many of the data have been already documented and collected in electronic medical records that are available for research. A clinical program for females for fertility preservation was already working at our hospital, but the methods that were developed before the starting of the cryopreservation methods in assisted reproductive could offer women only the treatment with fertility sparing surgery, so less radical and more conservative surgery in cases very well defined of early cancer disease, for example, of the ovary, of the cervix. So in these conditions were easy to establish a developed clinic for treatment of fertility that is also within the Karolinska Hospital. And at that center, we had dedicated researchers that were working in developing further methods of ovarian tissue cryopreservation, embryo cryopreservation, and some of them working at the lab as embryologists or working from the clinical part. The interest in improving fertility preservation and also the development of the method for cryopreservation working together, so facilitated also the establishment of a specific program for fertility preservation at our center. So we continue with the fertility preservation for men because this is not controversial at all. Also, many men have already frozen sperm at our center at the time we could start the fertility preservation for women. And we have published in this paper that was published in 2019, we explain how the programs were established at our center. So we had reproductive medicine specialists, but we were collaborative with pediatricians to include the cases of adolescents, for example. And also we work collaboratively with the oncologists to include the patients that also had malignancy as indication for fertility preservation. When we analyzed the data that we had collected from 1998 to 2018, we had already 1,254 patients. I don't want to bother you very much with this picture, but this is just to show you that when you have a program of fertility preservation, unfortunately, you don't have a final box where all patients end up there and a gold standard method that can work to everyone. So this is complicated because if women are adult or if they are very young, if they have a partner or if they don't, the methods for fertility preservation that can be offered they differ, and they differ also depending on the disease and the time available that we have. And you know, of course, all of this. But working with this cohort over 20 years gave us the possibility to actually measure what is the efficacy of fertility preservation in our cohort, how many of the patients come back to use their tissues and cells and embryos. And one important and interesting finding was that the efficacy of fertility preservation seems to be higher in women that have benign disease versus women that are presenting with malign indications. But it's also possible that there were people that have a malignancy, they have to wait longer time to be able to come back to use the cells or tissues they have cryopreserved. Specifically regarding children and teenagers in our cohort, so we had in 2018 178 of 1,254 cases. For those girls and young teenagers, we had practice ovarian tissue cryopreservation in 114 cases. You see the mean age was 13 years and the range from 3 to 17. And oocyte cryopreservation have we done in 24 cases, and it was mostly teenagers around 16 years of age with an age between 14 to 70. An important clinical development that we could see over the years when you can see the data, what happened over 20 years, is that an increasing number of young teenagers, they actually are interested to undergo hormonal stimulation for egg retrieval. And this is something that we could measure in 2018, but 10 years earlier. So we really could not see that was going to happen. And sometimes we have to start talking with the patients and let the patients also make decisions. This is the case that I'm presenting here. Is a 14-year-old girl with Turner mosaicism. And we were talking with this girl in the same way that we used to talk to children at that time and to adult women. An adult woman comes for fertility preservation, and we presented the methods of oocyte cryopreservation, embryo cryopreservation, eventually ovarian tissue cryopreservation in certain conditions. And when the girl came to us, so we presented the method that we offered to girls at that time, and it was systematically ovarian tissue cryopreservation. And then the girl said, yeah, but what do you offer to older women? And then we could tell the older women can undergo vaginal examinations, vaginal ultrasound, and ovarian stimulation to pick up mature oocytes that can be fertilized. And this girl was interested in undergoing this treatment, and she actually did it. So we did 2 cycles of hormonal stimulation with transvaginal egg retrieval for this girl during the school breaks. Of course, she didn't have cancer, and she had the time also to think and then make a decision, which has been useful for her because she has a good number of eggs that are frozen now. But this was the first case that actually put us into which maybe we should discuss with girls differently. Maybe girls are more mature than what we believe. Yeah, and then we have had this discussion with many older girls and even very young girls, And some of the girls, they are so mature, they want to do this, they know what they are doing, and they know why is that important for them. There are also other patients that think that this is too much, or I am not ready, or I am not interested, because probably there will be other solutions in the future. So the counseling of girls and teenagers is important, and we have had counseling together with a pediatrician and a reproductive medicine specialist in many cases for the very young patients. We have also developed age-adapted information in a version of younger patients and a version of older children, with plus information to the parents and consent that are signed by the children and also by the parents. And at all consultations, the possibility to undergo fertility preservation later on is also discussed, as well as scenarios in case fertility preservation is not possible or is not desired. And the patients can think about all the possibilities, such as egg donor treatments or adoptions as alternatives. And also for us, it's not difficult to discuss about egg donation, because we are also a center offering egg donation treatments that are also offered with within the healthcare system for the whole population. So we can prepare our patients with all this information for a future, because we don't know how the future is going to look like. I'm always pressing the wrong button here. One of the papers that Dr. Salama wanted me to present to you today is related to, or has to do with girls that have undergone an hematologic stem cells transplantation, and the issue of fertility preservation is important in this group. As I explained previously, we have started with a large program of fertility preservation at the end of the 90s, but the inclusion of prepubertal children in our program started in around 2002-2003, when we got the ethical approval to offer children the possibility to cryopreserve either ovarian tissue or testicular tissue. And this was possible also because the collaboration between pediatric oncology, the transplantation, the department, the pediatric endocrinology, and the reproductive medicine center are all there under the same. So this has facilitated our collaboration. In the study of girls that undergo hematologic stem cells transplantation, we could accept patients coming to counseling at time or when planning a hematologic transplantation, or after completion of the treatment. And depending on the patient's age and the clinical situation, we could offer ovarian tissue cryopreservation or oocyte cryopreservation. In the paper, I don't remember the list of the papers, but this is the paper of Vikander and collaborators. In this paper, we collected the data of 39 girls and teenagers from 0 to 19 years of age that came to our service for counseling of fertility preservation. Of those 39 girls, 34 underwent fertility preservation. You can see on the right part of the figure the patients that had a malignant disease and what are the most common diagnoses in this population. This is leukemias and lymphoma, and benign diseases in the left part or in the middle part of the figure show that we had aplastic anemia, thalassemias, and some other anemias and hematological diseases in the benign disease as the main causes. I said that 39 girls have undergone fertility preservation. 5 patients did not do it. And the reason was that when they came to our counseling, they had been treated with hematologic stem cells transplantation 9 to 17 years before the time of counseling. And all these 5 patients, they already have high FSH levels, so we could not actually offer them any possibility of fertility preservation. In total, these girls underwent ovarian tissue cryopreservation, 28 cases, and those were 16 for malignant diseases. And this is interesting because 11 did it before hematologic stem cell transplantation, but in 5 girls, it was done in the second remission. And I will show you what do I mean with this. This picture here is taken from one of the 3 papers that Dr. Salama wanted me to present to you. This is the paper on boys that I'm going to discuss at the end of my talk today. But this picture is consideration of acute lymphocytic leukemia in children. If we will have 100 children here in the first box with this disease, the children go to primary treatment, and 70% of the children are going to get cured after the first treatment. From these children, one treatment or primary treatment, 10 to 15% will be infertile in the top of the picture. So the risk of infertility is similar to the risk of infertility of the normal population. So a primary treatment for leukemia is not going to increase the risk of infertility in a specific way, different to what happens in the normal population. But some people, some children here have a relapse, or they also have what is called a high-risk disease. These patients are going to require extra treatment. And this additional treatment that is done here in position B is going to cause that the risk of infertility on top of the figure increases now to 50%. So these patients are at an additional risk of becoming infertile due to treatment. And if the patients come into remission at this position B, some of them are going to be cured only with this treatment, but some of them are going to be further to the right of the picture to a hematological stem cell transplantation. So the first position, A, is the first remission, if they are in remission, and B is the second remission. So you can understand now that the second remission means that the patient has already got a lot of chemotherapy treatment when the patient comes to this position, and this is before an hematological stem cell transplantation. If the patients go further to hematological stem cell transplantation, the risk of infertility is up on the top 98 to 100%. So it's really, really high. What is good, I mean, you can see in this picture, 93% in position D, they are cured. These are our children today with this disease. 93% are cured, and only 7% have a risk of death. So, if we go back to our hematologic stem cell transplantations cohort of girls, we did histopathology on the ovarian tissue from the cases where they cryopreserved ovarian tissue, and we could find follicles in 11 to 13 cases that were taken before conditioning for hematologic stem cell transplantation. But we also did cryopreservation of ovarian tissue for some girls after hematological stem cell transplantation, and we found follicles in 6 of 14 of the cases. And some patients also came for ovarian stimulation and to freeze oocytes. And some of the patients did it for the first time as the first method for fertility preservation, but some girls that already had frozen ovarian tissue, they came back and they also had still ovarian function, so we could perform ovarian stimulation, hormonal stimulation, and we could freeze some oocytes. In total of 9 patients that were receiving ovarian stimulation, 2 did it before hematological stem cell transplantation and 7 after. And all patients in this cohort had preserved at least 1 oocyte. But you see, for one girl, it's just 1 oocyte after 1 or 2 stimulation cycles. And the mean age was 16 years of age in malignant disease and 20 years of age in the cases of benign disease. The follow-up of this cohort has gone for over 17 years. And we can see that premature ovarian failure post-hematologic stem cells transplantation was proved in 3 of 14 patients with benign disease. This is only 21% of the cases. But premature ovarian failure was present in 15 of 21 girls that were treated for malignant disease, and this is 71% of the cases. The p-value shows that there is a statistical difference, and the reason is probably the type of conditioning, the number of treatments also that they received, the higher doses of alkylating substances. But you never know, because we also have had in this cohort natural conceptions in women with benign disease, even if they receive high-risk protocols. We have had three women that have undergone retransplantation of ovarian tissue. They all had in premature ovarian failure, and they all receive high-risk protocols also. And 2 of the women had children in another way. One has used donor eggs and one has done adoption to achieve a child. Our study showed that high-risk protocols were considered if they had melphalan or busulfan or high doses or other alkylating therapy in combination with total body radiation. The conclusion of our patients are that patients planned for hematologic stem cell transplantation should be referred for fertility preservation because the chances of fertility are very reduced, but methods to accurately predict which patients will lose fertility are lacking. Preservation can be performed before or also after hematologic stem cell transplantation. And patients that have cryopreserved ovarian tissue may benefit to additionally cryopreserve oocytes. And this is especially the case if the patient had a systemic disease at time of ovarian tissue cryopreservation that encompasses a risk of malignancy in the ovarian tissue. So in all cases, individual assessment is needed. And I think I will need some help because I cannot see my clock.
Yeah, no problem. You still have time.
I still have time.
Yeah. Okay.
Okay, I found a clock here in the room now. Good. Okay, so that was my first paper. I don't know if you would like to discuss it now or if you would like to, if I should continue maybe to the second paper that is also related to hematologic stem cell transplantation in just a specific case of a girl that had leukemia at time of the disease. And
yeah, yes, please. Yes, please continue your presentation. We are very happy to to listen here.
Okay. So the second paper that Dr. Salama wanted me to discuss with you or present to you today is a case report that we published recently during the summer on a patient that was 14 years of age at time of diagnosis of high-risk acute leukemia. And this patient had undergone that. All this happened in 2001. And the patient underwent treatment with cytarabine, prednisolone, vincristine, doxorubicin, and methotrexate. This is a NOFO protocol. NOFO is the Nordic Oncology and Hematology group in the Nordic countries. And the protocol is called NOFO ALL 2000. It's a high-risk protocol, high risk for risk of infertility that follows. But when the patient was treated with this specific protocol, she was in remission. And because the leukemia was a high-risk leukemia, she was planned for hematological stem cell transplantation. At that time, she was referred to us for counseling regarding the possibility to undergo methods for fertility preservation. We knew at that time that the patient was in complete remission because that was demonstrated by absence of blast in the bone marrow from the iliac crest biopsy. And also she had a negative lumbar puncture. And this was the result of this specific treatment that she had undergone. At that time, we didn't use methods to estimate the ovarian reserve in the same way that we use today. So in that case, we probably will have had an AMH levels and FSH or LH estradiol. But after such protocol, probably the gonadotropins could have been high and the AMH could have been very low as a result of just the protocol. The patient was counseled regarding ovarian tissue cryopreservation, but she was also informed, and the family, that at that time we didn't have any cases of retransplantation of ovarian tissue that had been successful. And at that time, we didn't know if we could use the tissue for transplantation later on, because there was the risk of leukemia potentially in the tissue. And many years later, the patient came back to us in 2016 as an adult woman with a partner, and she wanted to have her ovarian tissue retransplanted. We had additional problems, and sometimes we had molecular investigations that can be done from the disease at time of diagnosis. But for this patient at time of leukemia, we didn't have any specific molecular investigation done in 2001. However, we have a biobank of research for children with leukemia. And in the research biobank, we found that the patient had a sample of frozen blood cells that were taken at diagnosis. So working together with my colleague Gisela Barbani, she is genetician specialist in leukemia. She prepared the cells from the sample that has been taken in 2001 from the blasts that the patient had when she was sick. And those cells were used to establish what was the patient fusion transcript that was present in the blast cells of the disease. And it could be shown that it was the BRC, we used to say it in Swedish, so I don't know how to say it in English, but probably it's BCR-ABL. And she had the minor fusion transcript in the blast cells. And thereafter, we could use this transcript to investigate if it was present in ovarian tissue pieces that were found specifically for this safety analysis. We use in total 15% of the tissue that we have cryopreserved for this patient for the safety investigation. And we did 80 independent PCR reactions, and they were all negative. So after that, so we could tell the patient that we will be able to retransplant the tissue because the sensitive molecular method indicated that the likelihood to find leukemia cells in ovarian tissue was very, very low. But we could never say, never, we cannot say that it's impossible. But additionally, the patient was in complete remission at the time we retrieved the ovarian tissue. So this taken together reinforce the idea that the retransplantation of ovarian tissue could be done. Additionally, when a patient undergoes allogeneic hematologic stem cells transplantation, is the transplanted bone marrow that ensures surveillance and immunological surveillance. So it's very unlikely that if one or few cells of leukemia will have been present in the tissue, probably the immune response will attack this as graft versus host reaction. So we discuss all these steps with the patient. We involve the hematologist. We had our genetician expert in leukemia, and the patient wanted to go further on for ovarian tissue transplantation. And we consider that in such conditions that I have explained to you, it was a safe procedure and we could do it. So we did the first transplantation in November 2017. We transplanted 27 tissue pieces. This tissue has been frozen by slow freezing methods. The patient got menstrual cycles after 85 days. And this is really important for her because since she was 14, she has not a menstruation or a menstrual cycle, a spontaneous menstrual cycle. She has been, of course, in hormonal replacement therapy, but this was a natural menstrual cycle for the first time. We had a decreased gonadotropins later in 2018, and we did 4 stimulation treatments aimed at in vitro fertilization. We obtained only 1 oocyte and it was not fertilized. So we went for a second transplantation some more months later in November 2018, the remaining 19 pieces that we had now. After that, we didn't have any more ovarian pieces at our center in the cryopreservation tanks. She also got menstrual cycles back, and we did 1 stimulation treatment that resulted in 1 oocyte that was fertilized, and we could transfer a 4 cells embryo. And she got pregnant and delivered in November 2019. And after lactation and amenorrhea under 6 weeks. So she came to us because she wanted to know if it would be possible to have help to have a second child. And we discovered incidentally that she was pregnant at a 6 weeks pregnancy. And she delivered the second baby now in August this year. So this is a very successful case of ovarian tissue transplantation, but of course, after many very important questions about safety of what we do, and for many patients, this is one proof we don't have everything ready, and we have to develop the way to get the answer: could we transplant or not? And we develop specific tests for this patient to be able to go further on for the retransplantation.
We have now 50 minutes gone.
15 minutes, okay. Maybe yeah. I can very quickly, we'll go over the very last part, which has to do with the boys in our center.
Okay, because we need to have some questions. And
yes.
Yeah, yeah, sure. Okay. Okay.
Yeah, I think 3 papers was quite ambitious, that I should go for 3. But if we go very quick.
Yes, please. Okay.
On this study, so at the same time we organized a study for girls that underwent hematologic stem cells transplantation. So we included also boys for testicular tissue preservation, also because the methods for testicular tissue preservation were also available at our center. So similarly to the first study that I present in girls, so we have done a study in boys, and in this study we included 21 boys from 1 year of age to 14 years of age. And we offer testicular tissue biopsies. These were performed between 2003 and 2010. And we presented for boys that were pubertal, and we tried to encourage them to give a semen sample, but if they could not, so we could do the testicular tissue biopsy, as well as the prepubertal boys, because they could not attempt a semen sample. But the testicular biopsy was presented as an experimental method to all of our patients. And from these groups that were approached and offered the method, all the families were interested, except one family, but almost all the families were interested in offering this to the boys. So we did this together with the andrologist and the urologist of our center and the pediatricians oncologists. The counseling was similar to, as I explained, to girls, with very well designed information according to the age of the child. This is just to show you the diagnosis. This is in this cohort, most of the boys had cancer or malignancies, and 20 boys underwent an open testicular biopsy, 14 were prepubertal and 6 were in early puberty. In the pubertal biopsies, 2 contained mature sperm. So sperms were isolated and frozen, and the tissue was not frozen anymore. The tissue was used to recover the sperms. The biopsies were bilateral in 10 cases and unilateral in 10 cases. And this is something that we didn't have that defined in the protocol, and the urologist decided if the biopsy was too small, then could take another one from the other side. We used the cryopreservation by vitrification according to the methods that by Keros from our center. We had very rare complications, hematoma and infection in 2 cases. And from this cohort, we have 14 survivors. Of these survivors, the ones that have come to adult age have been contacted, and they were offered the possibility to give a sperm sample for analysis if they wish, but they didn't want to. So 6 boys have given sperm samples, and 2 had sperms that could be cryopreserved, and the all 4 had azoospermia. So what is important that I wanted to say to you today is that for the girls, we had the follicles in the ovaries from the beginning, and we have been able to make this tissue work even for transplantation in the future. But for the boys, we still do not have any possibility to use the tissue for their fertility. They are still very young, but more research is needed. At our center and the Karolinska Hospital, it has been formed, this group Not Fertile. They have a very nice homepage, it's easy to find, and this is dedicated to just the case of young boys and prepubertal boys that require fertility preservation, aiming to develop further the methods. And for females, there are very special and good guidelines, such as the one presented by Esre last year. And this is just my final picture. I just want to thank all the people that has given me support and my colleagues for this research. And I hope you can now come with your questions. I will try to put my camera. Thank you.
Thanks a lot, Kenny, for your fantastic talk. And we are sorry that the time really is very limited. I invite now my colleague, Dr. Leena Nahata, to moderate and manage the questions and answer. Please, Leena.
Yeah, sure. I mean, I think we have a small enough group. I think if people want to unmute and ask a question, that's fine too, just because it's limited time. One question, Kenny, can you just comment on the financial structure there for fertility preservation in terms of what families are responsible for?
Yes, well, as part of the healthcare system that we have for everything, so when we have medical need or a clinical diagnosis and we need a treatment, so everything is covered with the medical, what would you call medical insurance, but we don't call it like this. We just have the right to medical care. And fertility preservation is included completely in this. if there is a medical indication. So it means that women that do social freezing, they cannot claim this help. But everyone that has a diagnosis also or a reason to undergo fertility preservation doesn't need to think about how much does it cost.
And does that include storage, ongoing storage as well?
Yes. And there are, of course, rules and regulations, but I mean, the rules are if a man is saving sperm and it comes to 56 years of age, that cannot continue because there is a limit for fertility treatments for females or males, something like that, but it is very uncommon.
Sorry, can I ask a question? Hi, Kenny. Thank you so much for that wonderful talk. And I really very admirable for your case report on leukemic patients. Really congratulations with that. That's excellent. So what you did was you actually refroze some of these tissue pieces to do the testing, but you also wanted to retransplant these pieces. But what do you recommend, like looking forward? Should we take out small biopsies while we do the cryopreservation so we don't have to do the refreezing? And should we also take some medullas that we could test? Or when you look forward now, because we have also frozen a lot of these patients, but we haven't taken any tissue for testing, or just for testing anyway. So
yeah.
Just your take on that.
Yes, we have been thinking, if we will start to doing more testing at the time we freeze the tissue, this is going to cost a lot of money, and we don't know if we are going to use that tissue in the future. So the best is to cryopreserve the tissue, and when the patients come back, then we need to solve the problem. So do the specific tests that we need to do, whatever we need to do. It was a unique situation that we had this possibility to use blast cells from hair disease taken at the time of hair diagnosis of leukemia. And I don't know if these banks or biobanks are available at any hospitals, but this was a biobank of research at the Karolinska Institute for children with leukemia. Probably in the Nordic countries, some other biobanks are available for these children. The refreezing of the tissue, this is a problem that we have faced sometimes, because in the older times, we didn't annotated how many pieces of tissue were in each vial. So sometimes we have found the tissue and we had more tissue than what we actually believe it's necessary. So we have refrozen the tissue sometimes. And tissue refrozen has worked as well as tissue that has been frozen only once. So.
Kenny, somebody asked a question to clarify, is tissue cryopreservation only available to those at significantly high risk for infertility or for all new diagnoses? So how do you guys do your risk stratification there?
No, I think this should be offered to only cases of high risk of infertility, because if the risk is not that high, probably the situation can be reanalyzed 6 months later after treatment or 1 year after treatment again. And this is the case of an adolescent patient, maybe we can do fertility preservation in another way later on.
Yep.
Because I think if the risk is not a very high risk of infertility, the removal of one ovary is quite is a big decision.
Yes, agreed. Anyone else have any questions?
Dr. Rodriguez, thank you so much. I was wondering if you can comment on the size of the tissue that you're cutting them into strips when you freeze it, and then the size of the pieces when you put them back, and then where you're putting them back specifically.
Yes, well, the pieces that are frozen with slow freezing methods, they can be larger than the pieces that are frozen by vitrification. I think our pieces could be 4 millimeters, 3 millimeters, and 1 millimeter thick, something like that for slow freezing, or 3-4 millimeters by 1 millimeter thick, something like that for slow freezing. And the vitrified pieces have been smaller, And when we started to retransplant many years after we have started to vitrify, we discovered that the pieces were smaller and more difficult to transplant. So that was a problem. What had induced that we prefer now to do slow freezing for all the patients, and we don't vitrify very much the tissue anymore. And what was your only other question?
I guess after you thaw them, do you cut them into even smaller pieces to try and activate the tissue? You just leave them as is, whatever size they were frozen? And then my other question is, where do you transplant them? Do you put them in the opposite ovary that's not functioning? Do you make a pocket, or do you go underneath the fallopian tube serosa?
We haven't cut the pieces more before transplantation to activate them. We haven't tried that. Where we transplant, if there is an ovary in the right position, that's probably the best place to retransplant. And there are several methods that have been presented and published. And we have to transplant outside the ovary when we don't have more place in the ovary for more pieces. And I think that's what everyone also has faces difficulties. And then a good idea is to write very well in your operation description where the pieces are. Then you are going to be able to find them later in ultrasound examinations.
Thank you so much.
I think there's one more question. I just invited them to unmute. So if they want to unmute and ask.
Yeah. Can I?
Yeah.
Okay. First thing, thank you for the fruitful lecture. I just have one question. Is there any, okay, when you plan to plan the tissue back, okay, is there just one procedure or there are several procedures for planning the tissue back? I mean, is there any standard procedure for planning back the tissue?
I am not sure if I understand your question, but when we remove one ovary, we have a lot of tissue to retransplant, and we don't want to transplant all the tissue at once. So sometimes we can do maybe 25% of the tissue, 30% of the tissue, and then we will have the possibility to do a second retransplantation later on if the tissue doesn't work very well. I think there are many people doing research in how to improve the results of retransplantation of the tissue right now. So probably, or I am very hopeful that soon we will know better what we can do to make this tissue function better, to not lose so many of the eggs, because this is the situation today. We have transplanted tissue back in patients that have been irradiated in the pelvis, and we have transplanted back in patients that have undergone extensive surgery. So I don't think it's any limitation or how the patient needs to be for surgery. So I don't think there is any condition the patient needs to wish the tissue for fertility treatment. Probably in many countries, in some countries, probably the patient wants to have the ovary tissue back to recover hormonal production. This is also possible. But I cannot see that there is a specific condition to do this or not.
Yeah, you know why? Because we've been asked about the transplantation process, if it's complicated or if it's like regarding the patient, okay? Or even the healthcare professional, it's gonna be complicated for him or her for transplantation for the tissue back. I mean, after freezing.
It depends what disease the patient had, because some patients probably you need to do specific safety examinations of the tissue. If there was a systemic disease or a disease that can metastasize to the ovary, there is additional problems that you have to be sure that this patient can have the tissue retransplanted, because there is no risk or very, very, very little risk to reintroduce a disease with the transplant.
Okay, thank you. Because my question was regarding the patients, the social patients, not the one suffering from cancer, those who preserve the ovarian tissue for social reasons.
I don't think I can. I don't have any experience with this group of patients.
Okay, thank you.
Okay, so we are officially out of time, a few minutes after, but thank you so much for a really thoughtful and comprehensive review of your publications. It's really interesting to see, your structure there. I think those of us practicing in the US are definitely, inspired and a little bit envious of your cost structure for sure. We wish we could offer, this financial benefit to our patients, but hopefully in the future at some point. But thank you so much, and for all of you for joining and asking great questions. And we will be in touch with everyone soon with potentially another webinar in the future. So
thank you very much.
Thanks, Kenny, a lot. Have a nice day. Thank you, everybody. Thanks.